There's so much confusing and conflicting information out there around pregnancy and birth, and none of it comes from the people that are actually in the room. We are Sarah and Catherine, two Canadian labor and delivery nurses with over 4,500 births under our belts.
What if the nurse holding your hand during labor could also answer every question you were too nervous to ask your doctor?
Welcome to 4,500 Births Later. We have a special episode today with Dr. Beth Oming. She's an anesthesiologist, and we are going to call this one 4,500 Epidurals Later. Beth, why don't you start out with telling us a little bit about yourself and your background?
Sure. So I am an anesthesiologist. I completed most of my training in London, Ontario at Western. So I finished medical school and residency in 2019. So I've been in practice now for 7 years or so. I worked in Red Deer for a bit after graduating, and then I've been in Calgary at Rocky View since 2020.
Awesome. We love working with you.
Oh, ditto. The feeling's mutual.
So what drew you to anesthesiology and in particular obstetrics?
Yes. So I absolutely love my job, but I think the favorite part of my job is the OB anesthesia world. What drew me? Oh gosh, I think I just love helping women get pain relief in a very stressful and sometimes traumatic time. Yeah, I love swooping in there and just making a woman or a patient feel better. And I love being with families when they're, expanding their own family. And it's just such a special time. And I think we as anesthesiologists have an incredible opportunity to really make an impact on a patient's experience in labor.
Yeah, you absolutely do that on the daily.
I try.
And how many children do you have?
I have two. Yeah, I have two girls, ages 5 and 1. So I can also relate to the patients quite well. And I've had 2 cesarean sections. Yeah, so busy home life and work life, but it's pretty fun most of the time.
Yeah, exactly. So we're planning on doing some myth busting today.
Yeah, let's get into it.
Okay. So what is the most common misinformation that's out there with regards to epidurals?
Yeah, there's so much. I think a lot of the main things I hear a lot are, is there a perfect time to get the epidural? Some of the concerns around permanent nerve injury or paralysis, and really just breaking down what those actual risk numbers are. And I think there's a lot to get into, but maybe I'll start with the perfect time to get an epidural.
We get this one a lot.
Yeah.
Oh, yeah.
Do I have to be a certain centimeter
Exactly.
to get the epidural? Yeah.
And I always say the perfect time is whenever you want an epidural. That's the perfect time. I think that there historically was a lot of concern about, if I get the epidural too early, is that going to prolong my labor? Or, am I at risk for an instrumented vaginal delivery or cesarean section if I get the epidural too soon? And that's largely been disproven. And I think a lot of that has to do with, since kind of early 2000s, we've really changed the medication that we use in the epidurals. So we used to use much more concentrated solutions of local anesthetic, and the main ones that we use typically are bupivacaine and lidocaine. So we've really dropped that concentration because we've been able to show that you can still achieve good pain control without that dense motor block that we used to get, which I think was part of the main reason for that delay in labor progress.
So specifically epidurals, do they prolong labor? We get this a lot. I'm not going to get an epidural because it will prolong my labor. True, false?
Yeah. I think true, but it's really clinically meaningless, really. The American College of Obstetrics and Gynecology has said it can prolong the second stage for about 7 to 8 minutes. So, and that doesn't impact baby's outcome or mom's outcome in any way. So, and it's a relatively not pain-free, but reduced 7-8 minutes. So I'd take it, and I think most women would. But yeah, there's really no evidence that it can prolong your labor in any meaningful way.
Next question. Does an epidural increase the risk of an instrumental vaginal delivery?
Yeah. So the this is a common fear as well. And I understand, like, no one really goes into labor wanting a forceps or a vacuum. And I think kind of just what I alluded to. So if you still have good sensation of pressure and you're able to act or participate in the second stage, so you're able to push effectively, that's really not going to add to your potential for the forceps or vacuum. Yeah. It's tough because, if you have a large baby, for example, and or they're in an odd position, any combination of things that can happen. But if a woman has more pain, then typically we end up giving them more top-ups or a bit more in the epidural. And so they can have a little bit more of a dense motor block, and that can impact pushing. But, in the end, it's treating women's pain. And we have lots of different ways we can get that baby out if we need to. And yeah. Does that make sense?
Oh, 100%. It does.
If we can really just simplify what an epidural is.
Exactly.
Where does it go? What does it look like? All the simplicities of exactly what an epidural is.
Okay, so what an epidural is, the procedure itself is very straightforward. We essentially just place like a really thin, flexible tube in something called the epidural space, which is really just a potential space that is just before the spinal cord and where your spinal cord lives with all the spinal nerve endings and the fluid. So there's this kind of sac, almost like a sac right before there, where we can place a little tube and give medication, whether that's the local anesthetic or other pain medications like morphine or fentanyl. And we can administer medication in that space, which eventually kind of diffuses across that membrane, which we call the dura, to reach the spinal nerve roots. And when they reach those nerve roots, they can prevent transmission of pain signals through the spinal cord up into the brain. So you really just don't register the pain that's happening. And there are a lot of, so there's different pain fibers and they're all susceptible at varying amounts. So, which is why we usually can, what we call a walking epidural, where you have control of your legs, you have good motor strength, but you don't have the pain. And that's like the perfect situation, right? So those motor fibers are actually more resistant to that local anesthetic, whereas the pain, the temperature is kind of more susceptible. So those are the things that go first. And then in the middle, you have things like touch and pressure. So, which is why you can have epidurals where you don't feel anything, and that's sort of more of a dense or heavy block. And then you can have epidurals where you may still feel the touch and pressure, but it's not painful. And that's kind of that sweet spot we try and aim for. The other common question is, what's the difference between an epidural and a spinal? So with a spinal, we're actually intentionally going through that dura layer, but with a much, much smaller needle because we don't need to place a tube. And so we actually put medication directly into that intrathecal space, we call it. So it's a lot faster acting because you don't have to wait for that medication to penetrate through that tissue layer. It also is a main reason why when we talk about things like spinal headache, why if you have a spinal, you're a little bit less likely to get that dural puncture headache or that spinal headache because that needle is so much smaller. Whereas if we go in and we're placing an epidural with a larger needle, because we need that tube to be able to pass through the needle to be left in place. So if we accidentally puncture the dura with the epidural needle, it's a much larger needle. And so your risk of headache is higher because you create that leak and you get that leak of fluid, which creates the hypotension that your brain sees, which registers as headache. Sorry, I went really deep.
I liked that. Just out of curiosity, from your point of view, is it easier to place an epidural than a spinal needle, or are they about equal?
Sometimes spinals are a bit easier just because you don't have to leave something in place, and it can be a little bit trickier just to find that epidural space, and you're more cautious because you really don't want to create that hole in the dura because the risk of headache, if that happens, is like 70-90%, so quite high. So we're a lot more careful, whereas with the spinal, not that we're not careful, but we don't have that concern in the back of our mind quite as much, that risk of headache.
Right.
And it's also, you get that kind of immediate feedback that you're in the right spot because you get that spinal fluid coming back through the needle. And so it's satisfying that way.
Yeah.
Yeah.
Usually you can tell it's going to work well. It doesn't always, though.
Which we'll get to in a little bit.
Exactly. I was just thinking as you were talking, we've come so far with using the lighter dose cocktail.
Yeah.
So when I first started in obstetrics, if a woman had an epidural, it was a very dense block. And often they weren't able to move their legs.
Yeah.
And when it came to pushing, we'd either have to half the dose of the infusion amount or turn it off and let the sensation come back and have hands on the belly and tell them when they had a contraction. And they kind of had to use their imagination as to where to push, trying to activate something that was so numb. So it's amazing how far we've come.
Yeah. And I feel like a lot of women didn't like that. Like they wanted the pain relief, but they still wanted to be able to have some sensation, right?
Oh,
Be
yeah.
able to walk to the bathroom, even go on hands and knees. Like I'm always amazed when I see a woman with an epidural and they're just laboring hands and knees. Yeah, that's great epidural.
Just to be a little bit more specific about a walking epidural.
Yeah. I think that kind of came around when people were using a medication called ropivacaine, which has a little bit more of that motor sparing property. But then we also realized with just lighter doses of lidocaine and bupivacaine, you can achieve motor function. And when we say walking, like you're not walking around the hospital once you have an epidural, but if you can walk around the room or go to the bathroom and, that's what we kind of consider a walking epidural. So it's a bit of a misnomer.
Right.
Yeah.
And you don't worry about the block dropping if they're standing up.
I mean, that does happen. Yeah, that does happen because, it does work a little bit by gravity. And so especially in the second stage, you don't mind because you want that freezing that's like a little bit further down. But in the first stage of labor, you do want that higher block. Like typically we aim for T8, T10 is ideal.
Can you just explain what T8, T10 is for our listeners? We get you.
So those are dermatomes, and that's just a way of assessing block height. So typically that's done with ice or pinprick or touch pressure. And it's easier to just show a picture, but basically T4 is kind of at the nipple line. T10 is the umbilicus. And so if you kind of imagine you want the freezing kind of halfway between there. If you're having a spinal for a cesarean section, you want that freezing kind of at the nipple line. And sometimes it can go a little higher, but that's okay usually. Yeah. So that's kind of just a way we can see the block height. And that doesn't always mean, if you have a T4 bilateral block, you can still move your legs usually with an epidural. Does that make sense?
Mm-hmm.
The dermatology, you just need the picture.
I know. I need the picture.
The anatomy helps,
Yeah.
right? And most pregnant women, their nipples are in an appropriate place.
Yeah.
We talked about the timing, pain management. That is seen as a personal failure. Oh my goodness.
Oh my
we
goodness.
get this.
Yeah,
we get
you
this.
guys know. It's so frustrating what women can convince themselves like that they're either not deserving of pain relief or that it's a personal failure if they can't bring their baby into this world unmedicated. Like I can just see the pain sometimes when they feel like it's, I guess I have to get the epidural. I'm exhausted and I just want people to know like it's okay. And so many women get epidurals or, it's okay to ask for pain relief in labor. It's okay to do it the other way too, but it's certainly not a failure on your part if, it was your original, it was in your birth plan or, what have you to avoid medication at all costs. Like things change and it's painful. It's painful.
Yes.
Mm-hmm.
Yeah.
I think a lot of it too is what I've read online is they call it a cascade of interventions. So it starts with the epidural, and then as you have just smashed with your myth busting, it prolongs labor.
Yeah.
You end up with a C-section, et cetera, et cetera. So I think that's a lot of the reason why women don't, because they think it's the first step of an intervention that's going to cause 3 more interventions.
Yeah, that's fair. And, you need the IV with the epidural too. And, but, if you're having so much pain, like it's often either it's your first labor or it's a large baby or baby's in a funny position or you have a narrow pelvis. Like there's so many reasons that your pain could be worse than what is typical. And, if you're a multip coming in and, you've experienced birth before and it's been straightforward and you're moving fast, like that's kind of a different story than your first time induction. Inductions are also a bit more painful, right? So I don't want women to feel like they're failing themselves or their baby.
Mm-hmm. There seems to be a common theme with people recently that we've interviewed, and it's the language around birth, and to make a conscious effort to make it more positive.
Yeah.
Right? Like removing that word failure.
Yeah.
You were in the moment, and that's what you needed at that time, and you're
Yes.
doing the best that you can do. And if that means that you come into the hospital, you're in rip roaring labor, and next thing you know, you're holding your baby in your arms, awesome.
Yeah.
But if you are at a point in your labor where you really need pain relief, get it.
I know. And then, I've seen so many times where, the women finally get an epidural, they're able to rest for a couple hours, save up some energy, and then able to push out their baby. And it's beautiful. So
And-
sometimes you do need that rest.
Yeah.
Mm-hmm.
I've noticed as well in my practice that a patient will be the same centimeter. So 4 hours later, she'll still be 4 centimeters. 4 hours after that, still 4 centimeters without an epidural. And then she finally is exhausted, decides to get the epidural. And all of a sudden she, like you said, has that nice sleep. Is there something there? The uterus relaxes?
I think so. The whole body relaxes. And
we have them sitting at the side of the bed, 8 centimeters, waiting for the anesthesiologist. And then we say, okay, the anesthesiologist is 1 minute away. And then all of a sudden they are ready to push. I feel like it's something in their brain that they know
relief is coming one way or the other.
Yes. It's like when you have to go to the washroom, there's a toilet nearby. So just from my experience, that's what I've noticed is the pain relief actually helps with the cervical dilation at times.
Yeah, absolutely. Yeah. And I think, if you did end up needing a instrumented delivery, there is huge benefit to having an epidural because, we can do things like IV pain medication. And I feel like a lot of women maybe have this backwards that is somehow safer. But it actually is not. There's a limit to how much we can safely give you. It causes much more maternal sedation than an epidural would. And it's just not as effective. And then some of that medication does go to baby because I do think it is important to be aware of the other options. Obviously the epidural is really the gold standard. Prior to that, or, in the earlier stages, if you're not quite ready for an epidural, there's lots of ways we can manage pain. You'll hear of the nitrous gas, which some women just really don't like. And I always kind of think of that as like a temporizing measure before you get your epidural. And then I do see a lot of women getting benefit from those TENS machines. Do you agree?
Oh yeah, 100%. I wish we had them
at the hospital.
Yeah, a triage, and then we could, because they're guaranteed to come back. You come in early labor, get your TENS machine on, go home, and then come back later. You'll be bringing it back.
Yeah, or I'll take it off before I put your epidural in.
Exactly. Yeah, they work really well.
Them. Yeah, I think they help. The combs help a lot.
Mm-hmm.
Yeah, in the early. And then, there's obviously the IV pain medication. And sometimes this is really our only option if there's a contraindication or you're unable to get an epidural for specific reasons, which aren't that many, but there are some. Things like if you had a really low platelet count or, you had scoliosis surgery as a child and you have those rods and you just, it's just really difficult to place an epidural. So there are options for IV pain medicine, but as I kind of spoke to before, there are some significant downsides to those. And, not to say that epidurals don't have their own risks, and I'd love to get into that too.
Mm-hmm.
But I think they've come such a long way in their overall, they're so safe these days. I've been doing this for 7 years, definitely a couple thousand under my belt and knock on whatever wood you can find. But I have not seen any permanent nerve injury or any really serious complications from an epidural. So, or in laboring patients, I'll say, it does happen in we do epidurals and spinals for all sorts of reasons in the main OR. And, but I think, when you're fairly young and healthy and in labor and it's only in for a short period of time and, pretty safe.
What are those risks?
Yeah. So main risks, I'll kind of get my spiel.
Yes. COVID gave us his spiel.
Yeah, I heard it.
I love it.
I've heard it many times.
The spiels. Yeah.
I like the spiels. I usually start off by saying, this is what the procedure will look like. It'll take me 10 to 15 minutes. I'll work around your contractions and with you. You just kind of let me know when you feel one coming. Usually we can get the epidural in or do the part where we need you to stay still between those contractions. Takes 5-10 minutes to start working once it's in. And that's kind of like a gradual, it can drop your blood pressure in the beginning. We do see that quite a bit. And that can sometimes drop baby's heart rate. Most of the time with repositioning and IV fluid, we can bring that heart rate back up and it's just a temporary thing. But, I have seen it where, okay, baby's heart rate's not recovering, even though the blood pressure is good now. And we do have to go to cesarean. And I often wonder, is that just because baby was having some issues before the epidural? Yeah, whether it's D cells or, a cord wrapped somewhere and they just really don't tolerate that like transient drop in blood pressure and blood flow to the uterus.
Yeah.
What else? There's that risk of the dural puncture headache. So I usually quote about 0.5 to 1%. So 1 in 100 or 200 women. Usually we'll know right away. So we get that kind of rush of spinal fluid through the epidural needle. And we know that once that happens, you're about 75 to 90% risk of getting that dural puncture headache, which is not just, a typical headache. It usually occurs on the second or third day after your epidural has been placed. It's really positional. So that's kind of the main defining characteristic is it goes away when you lie down. And as soon as you sit up or stand up, a terrible, like really awful headache. And it's just from that low pressure from that leak of spinal fluid. And it's temporary. It usually is like 1 to 2 weeks of a bad headache, but it can be quite debilitating. And I'm sure you guys have seen spinal headaches or have heard, and it's, one of the more common things that can happen with an epidural. But we do have ways to treat it, and that's with an epidural blood patch, which I can get into later as well if we want. So the spinal headache, that's the one kind of major risk that can happen. Epidurals aren't always perfect. I usually try and set some expectations. Like our goal is to, if you're in 9 or 10 out of 10 pain, we want to kind of get you down to that 2 or 3 out of 10 range where you're still having some sensation, some pressure. You're able to walk to the bathroom. But some women want to feel absolutely nothing, which is doable, but does have that drawback of no motor function usually. What else? Sometimes you can get patchy or one-sided blocks where you have, I'm sure you've seen this, where you're testing them with the ice and one side is a higher dermatome than the other. And I don't usually get too worried about that unless the pain is one-sided. So, and then we have tricks. We can pull back the catheter. It's often just, it's gone a little bit too far and we just need to pull it back. Sometimes we do need to redo it though. If we're not happy with how the block is behaving or it's not giving you enough relief, then usually we'll offer a second procedure. And then the extremely rare things, but that are potentially quite serious if they occur, would be infection, bleeding or a hematoma, and then injury to the nerves. Now with infection, with sterile technique, this is very rare. With the hematoma, it's just because we can't compress that area. If we do nick a blood vessel or you go into DIC or your platelets drop suddenly and you're at risk for not being able to form those clots as well as others, then you can get a hematoma. And if it occurs kind of and compresses the spinal cord, then that can become a surgical emergency. But again, I've not seen this myself in a labor epidural. It does happen and we are aware of it. We're always monitoring. So if you have like sudden weakness a couple days after you had an epidural or new onset severe back pain that's like really out of the ordinary, or tenderness to the back. Yeah, those are things that you'd want to come back into hospital for. Then when we talk about nerve injury, so this is probably one of the big myths or misconceptions that I see a lot of, like, oh, my friend had an epidural and she has chronic back pain. No end of stories. I think just having a baby in general, you're just at risk for nerve injury. Just that baby passing through your pelvis, just being in the stirrups for a couple hours with your legs. You get that common perineal nerve injury, which is a nerve that's on the lateral aspect of the knee. And so if you have an epidural where, you don't maybe have as much sensation in the leg and you're in stirrups for 3 hours pushing,
Right.
you can have a temporary foot drop or just a temporary nerve injury to that nerve that innervates the foot. So is that from the epidural? Well, kind of in a way, if the woman wasn't able to say, oh, I'm kind of having some tingling in that leg. Let me reposition. But from the epidural itself, it's quite rare. Yeah, I think we say 1 in 250,000 for a permanent nerve injury. And that doesn't mean paralysis. That just means a nerve injury that's not resolving. Still usually able to walk. Yeah.
Yeah. Just one of the things you brought up was the fetal heart rate, the initial drop. I find a lot of people like to blame the epidural on the reason why they had a cesarean section. If there's fetal heart rate issues down the road, they like
Yeah.
to say it's because it happened after the epidural.
Yeah. I know. And it's really hard to convince someone that it's probably, you were probably going to end up in a cesarean anyways if
Yes.
baby was that sensitive to that temporary change in your blood pressure. Like there's usually like a cord compression or
Yes.
something. Yeah.
I have noticed though over time, making sure the woman is hydrated and how some people will do the 500 ml bolus before getting the epidural, that prevents usually that 10 to 20 minute prolonged
Absolutely.
deceleration that can happen, which is
Yeah.
really, really nice that it
Yeah.
can prevent it.
And that's why I'll stay in the room usually in that kind of first 10 minutes, 15 minutes, because if I can give you medication, whether that's to boost your blood pressure, or just the IV fluid bolus, yeah, I try my best to prevent that from happening. It also makes women feel lightheaded or nauseous too. So, yeah, I really try not to have that dip in blood pressure, but it does happen. And I think just treating it quickly and staying hydrated is so important. If I see a woman has just gotten their IV and now they want their epidural, I'll keep that IV wide open, just get a little bit more fluid into them and maybe not, load them up so quickly with medication. I'll be a little bit more careful.
Yeah.
Or if baby's had some decels already and I'm putting an epidural in, I'm a little bit more careful.
Now, when you were talking about IV medications, there's fentanyl. Can you talk about that a little bit? And if there's anything else that you like to give through the IV?
Yeah. So we actually use fentanyl IV and in the epidural. I much prefer giving fentanyl in the epidural because you really don't get that sort of maternal sedation quite as much, and less goes to baby. Yeah. So in our epidural bag, it's usually the one that we stock for the most part at Rockview is the 0.8% bupivacaine with 2 micrograms per mil of fentanyl. So you do get a little bit of fentanyl in that epidural medication. That can sometimes lead to a little bit of an itch, or pruritus is the fancy term. And it's this really unpleasant full body itch that you can't really scratch. But if that's an issue, that's not an allergy. That is a side effect. And we can actually just take it out of the bag and just mix a completely local anesthetic only solution. But it really does help with that pressure sensation. And so often if you have a really nice block like T4 to ice, but you still have a lot of that really intense pressure pain, then that's where we're thinking, oh, we'll give a bit of fentanyl in the epidural. That should help with that, but it shouldn't raise your block height. If that makes sense. We can also use it if I have a woman who's really far along in labor, multip, really having trouble staying still, but is desperate for pain relief. We can give a little bit in the IV as we're doing the epidural just to help with that positioning. And I think you guys see that a little bit. Yeah. Yeah, it's helpful. I'm always wary of giving medication that will sedate mothers because it's already such an exhausting experience that I don't want to add to your exhaustion with medication. So yeah, that's another reason why epidurals are so amazing.
Yeah.
That's very considerate.
Yeah.
Now, when patients are concerned about fentanyl,
Yes.
because of the fentanyl crisis, and it just has a real bad
It
rap,
really does. Yeah.
what do you say?
This is medical grade, hospital grade medication that has a purpose, and we're using it in a situation that is warranted and safe and monitored. But I get it. You hear about it all the time on the news, but it is safe, and we use as little as we can. And Yeah, it's a very controlled setting.
And you have such a nice voice. I'm sure people are, oh, okay then.
Yes.
Yeah, I trust you.
And then the other one that we will use a lot is morphine, and that's usually more in cesarean sections. So we're adding that into the spinal medication, or if you need an emergency C-section and we're topping up your epidural, we're adding that into the epidural because morphine kind of sticks around. So you get that longer acting pain relief. We usually say about 24 hours. So that's why when you have a C-section, that first 24 hours, pain isn't usually too bad. It's day 2 and 3 when that morphine wears off that it can get quite sore. So
I remember that. Yes.
yeah, me too.
Yeah. Not very nice.
No.
This kind of leads us to the next set of questions. C-section anesthesia. Big topic here. Can you walk us through what anesthesia looks like during a planned C-section versus an emergency one?
Yes. So yeah, I loved the planned C-sections because it's just a lot more calm and you have time and you can play some music. Typically those are done with a single shot spinal anesthetic. So you come into the operating room. We get you sitting on the operating room table, getting into that same position as we would get you for the epidural. So really curved back. Clean your back with a cleaning solution, put some freezing or numbing medicine in the skin, and then go in with our really small spinal needle. Once we get that spinal fluid coming back, we know we're in the right spot and we can give you our medication. It's a lot faster acting than the epidurals. So you do get that drop in blood pressure a lot faster than you would with the epidural. And then typically I describe to women, you're going to feel some warmth, tingling, and heaviness in your legs from the top of your tummy down. You won't be able to move your legs for a couple hours. And I keep a really close eye on your blood pressure. And usually you need medication to kind of keep that stable, the blood pressure, that is. And I'm with you through the duration of surgery. And if you have pain at any point, you would communicate that to me. So that's kind of the planned situation. When you have an emergent C-section, there's kind of different ways we think about it. So if it's a true emergency, like E0, really no time to load that epidural if there is one, or do a spinal, then we're thinking general anesthetic, which we're trained for. We do all the time. So it can be a little bit scary, just that lack of time. And that's just a bit of a whirlwind. Then there's E30, E1, let's say your labor has stalled, or you've been pushing for hours and baby's not coming down. Decision made to go for section, but baby's heart rate's good and you have an epidural, then we can talk about loading that epidural or an epidural top up. So we just give you much more medication that's stronger. You get that motor block starting, and we have various ways to test to make sure that it's going to be adequate for surgery. Typically either general anesthetic, spinal anesthetic, epidural top up, or sometimes we can do a combo of the two. So a combined spinal epidural for specific situations. Yeah.
Thank you.
So when you're in the operating room, and let's say I had a book C-section and the spinal went in beautifully, the middle of the C-section, I'm feeling it, not just pressure, but I'm feeling pain.
Yeah.
What happens?
Oh gosh, this is I'm so passionate about this topic because I feel that we've brushed off pain as pressure for a very long time, and or just not believed or listened to women enough when they're saying they're having pain. Well, I checked the spinal was good. It was easy. It was straightforward. I think it's so important just to believe patients first and foremost and show them that you are there for them and with them. And then, you talk about what to do next. So obviously, if you're in the middle of surgery, you can't exactly sit the woman up and put more medication in the back. So then we have to talk about things like IV pain medication. Or if that's really not doing the trick, then we talk about converting to a general anesthetic. There are a lot of opinions on sort of best medication to give IV to supplement if there is some pain, or sometimes that pressure can even be so painful. Like it's just so intense that it's almost feels painful, even though it's really more pressure. But so we can give medication like fentanyl, like propofol, like ketamine, like something called dexmedetomidine, midazolam. There's so many different ways. We can also, dial in the nitrous gas too from our machine. So, but I think making that decision to convert to a general anesthetic is always a challenge for an anesthesiologist because we have to weigh things like how far along are we in surgery? Is baby out, baby not out? Or, is this a situation where she's at really high risk for bleeding because a general anesthetic can kind of relax those uterine muscles so they don't contract as well. So you're at a little bit higher risk for PPH if you're under a general. We have to think about their airway. So, and this is something anesthesiologists are always looking at is the airway exam. And basically that's just a way for us to know or get a sense of how easy it will be to place that breathing tube, which is necessary if you're going to have a general anesthetic. And sometimes it's really challenging in pregnancy because you have more airway or tissue swelling. People come in all different shapes and sizes and some just basic anatomy. You can be normal BMI and still have a very challenging airway. So these are all things we're thinking of because we might have a higher threshold to convert to general if we're really worried about losing that airway.
Right.
But I also feel very strongly that pain should be managed. And I don't want to ever just sedate pain because that's kind of just masking pain. And a lot of those medications can, like ketamine, for example, it can be unpleasant, those sort of dissociation and those hallucinations that can happen. So there's, pros and cons to it all. We're constantly checking in, or like I'm constantly checking in with my patient, but I fully recognize you're lying on an operating room table mid-surgery. You're not in the best position to be able to make those decisions. And it's so hard, right? So I'm kind of there as your guide.
Yes.
What's the next best step here? Because, just pushing through and tolerating pain is a no for me. Like, we're not going to just do that.
Well, and the great thing for women that are out there and they're having a C-section, if you can imagine you're lying on this table, your arms are out at your side, but your anesthesiologist is right up at your head.
Yeah.
And so you can tell them anything. Like, I'm feeling nauseous.
Yeah.
I'm feeling nervous. I'm feeling,
want to know it all.
Yeah.
Tell us because sometimes that nausea is just your blood pressure dipped a little bit and we can fix that. Or we can give you the nausea medication a bit earlier than we would have. Talk to us. We're there. I also love taking pictures when baby comes out and we drop the drape, and it's just such a beautiful moment. I feel like I've taken some National Geographic worthy pictures.
Oh, wow.
Yeah. Oh, nice. Very nice.
Just to rewind, go back a little bit to make it easier for the listeners. Can you just explain in very simple terms what a GA or a general anesthetic is?
Yeah. So that's when you are given a lot of IV medication quickly, such that you lose consciousness and you aren't able to sense pain. Now, when we give you all that medication, you lose the ability to protect your breathing and your ventilation. So we use our ventilator to take over and help breathe for you while you're under that anesthetic. So typically it's a process where you get off to sleep with IV medication, a breathing tube is placed, the ventilator is attached to the breathing tube, and we assist your breathing. And then we can maintain or keep you asleep using the anesthetic gas, which is usually sevoflurane. And that's pretty typical, pregnant or not. If you're having a surgery where you need a general anesthetic, that's kind of pretty standard stuff. So we do it all the time. We don't do it as often in the OB world for some of those reasons I mentioned. So it can be a little bit kind of scary when we're doing it in an emergency situation, especially. And we really just want to get baby out as fast as possible. But, I'm also taking care of mom, and it's hectic, but we know what we're doing.
You sure do. This is kind of a side note, but as nurses, sometimes, you're out and about in your everyday life and you see someone's arms and their veins and you're like, oh, wow, those are really nice veins. Do you find when you're walking around, you check out people's airways?
And veins. Yeah. Veins. Yeah. Or just, that person would be challenging to provide an anesthetic to. Yes. All the time. Yes.
That's awesome.
You had mentioned also with the general anesthetic that one of the things you consider is whether baby is out or in.
Yeah.
So if you could explain that a little bit.
Yeah. We do know that medication, most of the ones that we do give will cross the placenta, and it's usually not a big issue, but that's why we have our lovely NICU team there for all deliveries, but especially when it's a general anesthetic. I think they usually bring in a few more people, but if baby's still in, then usually we try and save the things like the fentanyl and the morphine until after baby's out, because we're using much higher amounts. If a woman has really high blood pressure or cardiac condition that makes things like propofol a little bit less safe, then we might just give a little bit of opioid with the start of the general anesthetic where you're going off to sleep. But typically, yes, we try and give bare bones. Usually it's propofol and succinylcholine. And then once baby's out, we give the fentanyl. And that's just to try and improve baby's outcome and hopefully that they won't need any like naloxone or respiratory support, things like that.
I know when there's a general anesthetic, the anesthesiologist and the OB work very closely together.
Yeah.
With the spinal, they're outside of the room, but with the general, they're at the bedside, ready to go.
Yeah,
And
we
you guys-
usually wait until like the drape is up, the OB team is ready with the scalpel in hand, and we make eyes across the drape and I say, "Are you ready?" And they say, "Yeah." And I usually have helper, whether that's one of you guys or a respiratory therapist or one of the anesthesia residents. Then we say, "Go time." We'll give you medication in the IV. You're breathing in oxygen through a mask, and then you go to sleep, and then you wake up and your baby's right there. I feel like most people prefer to be awake and present during the delivery of their baby. Not all women, and this is something I'm starting to change my tune on a little bit in the last couple of years, mostly because I listened to that retrievals podcast in season 2, and it really kind of made me question that decision to convert to general. I think I have a lower threshold to do that now in general because it can be so traumatic to have surgery and still have sensation. Full stop.
Yeah.
Now with when a woman has a general
Mhm.
and she's waking up,
Yeah.
often she could be quite confused.
Yeah.
So can you talk about that a little bit? Because that can be a bit distressing for them. There's a little lapse in the memory.
Absolutely.
And then for their partners too, they can be like, what's going on? Why do I have to keep answering the same question?
Yeah. That's often from Dazalam, like medication to reduce awareness. So that's often given after baby's out as well. But yeah, I mean, all these medications, even just the sevoflurane, like the anesthetic gas, you can be quite disoriented. It's usually short-lived. So especially if you have people that, can quickly orient you, like your partner, like meeting her baby, like seeing the nurse's familiar face that checked you in that morning, or getting your glasses back on.
True.
Yeah. So usually it's like a 10, 15-minute thing, and then you're tired, you're groggy, maybe a little bit, you're maybe a little bit sore, but usually you're feeling okay after that 15 minutes. Depending on what medication, like ketamine can last a little longer, and yeah. And everyone wakes up differently. Everyone kind of responds to anesthetic differently. And a lot of it, I think, depends on your mind state going into surgery too. So if you're like really panicked and, it's really a stat C-section, yeah, you're probably going to be a little bit more disoriented. Yeah.
Now we were talking about this yesterday and you do such a brilliant job of this. A lot of people feel that when they have an emergency C-section, their birth story is over.
Oh, yeah.
And so I know you make such a point of playing music and skin to skin and all of that. So can you kind of speak to why that's important? What kinds of things we can do in the OR to make it a special experience?
Yeah, thanks for asking that. Yeah, really passionate about this because I think just like the overall experience that we can provide for a patient is just so important. People have shown that, really traumatic birth experiences, women won't have another child sometimes because they just do not want to go through that again. So I really try and do everything in my powers. And that's very individualized. So whether that's music, if skin to skin is really important to you and baby's doing well, like I really try my best to make that happen. I'll get family pictures. if things don't go perfectly smoothly, I'm always there to debrief after. Like I always check back in, what questions do you have? Explain my decision making in the moment. Cause I find that can be a little bit like, especially the partners too, like, and, if they're having to leave the room, if we're converting to general anesthetic, I just want to make sure that they're supported as well. Especially because if mom is having a general, then, she may be a little bit confused. So if you can explain yourself to the partner I know is going to be able to reiterate what I've told them to mom when she's more lucid. And I still like to involve them. Like I'll often bring dads in if it's a general, if they're reasonable, and have them sit and hold mom's hand, even though mom's asleep and has I have to frame it like, partner's going to have that breathing tube. This is what it's going to look like. There is a little bit of tape on her eyes just to protect the corneas. But if dad can be there for the birth of the baby, I think that actually makes a big difference for mom to know that her partner was there too, with her the whole time, never left her side.
That's beautiful.
Yeah. But I think the debriefing is so important. Being able to answer any questions, prep them for, why did my spinal fail? Or why didn't we have time? Answering those questions. And when it's a little bit calmer, you're holding your baby.
Thank you.
There is a thought out there that natural childbirth is superior or better. Where do you think that comes from? And what are your thoughts on this?
Oh gosh. I think in part it comes from just fear. There is a lot of distrust in medical professionals and in hospitals, and I understand that. Things happen, mistakes are made. So I think the whole thinking of I can just avoid any interventions, just kind of listen to my body, my body knows what to do. I think those are valid thoughts to have. It's just, it doesn't often play out like that. I always say, like, if you're going into the dentist for a root canal, like, you're not going to do that without freezing. So you don't have to have an epidural. You don't have to have any pain medication in labor, but it is an option. It's a great option. And I feel like just being open-minded and knowing that you can change your mind at any point. You can start your labor unmedicated. You can see how it goes, right? I personally will put an epidural in anyone who wants one, even if you're like, unless I see baby's head, you
Unless
can get
she's
something.
crowning.
Yeah. Unless, we're right there. I will always try my best to offer you something. So yeah, I don't know that's a really difficult question
I
because
know.
it's so like the societal, like the misinformation. I just listened to that, Free Birth Society podcast. Have you listened to that?
Yeah.
Just chills, like, but you can understand why women kind of get drawn into that whole world of like, I get it. Yeah, I don't know. It's like such a hard thing to answer. What do you guys think?
I wish that people could be a fly on the wall and see what we see.
Yeah.
Because I have seen beautiful deliveries without epidurals. I had one just the other day. It was fabulous. She had the TENS machine.
Yeah.
It was amazing.
Yeah.
And very same day, I had another patient who was struggling. She had been up for 48 hours.
Yeah.
She was exhausted, but she had this seed planted that she, under no circumstance, was getting an epidural. And she was sobbing, and she was at the end of her rope. And that was the situation where unchanged. She was just getting more and more defeated. And so in the end, she did decide to get the epidural, and big smile afterwards. This is the best thing I ever did. Why did I do this? We hear that all the time. Why didn't I do this sooner? So I just wish patients could be a fly on the wall and see what we see, because there are some that okay, this one, she's gonna rock this. Typically second babies.
Typically, yes. Yeah, I know. And it's a beautiful thing. I mean, birth is beautiful. no matter what. I think you just got to do what's best for you. And be open because things happen. I just want women to be able to have pain to be managed. But if it's something that you are like really keen on having an unmedicated birth, like we're totally supportive of that too. We're not going to push you either way. But I worry that a lot of that kind of like those fears around the epidurals, like they're just not founded, or women get these notions that they're going to be paralyzed. And it's really hard to explain that to someone who's actively contracting. And there have been studies that have shown that women are very capable of weighing risks and benefits, even if they are in amidst intense labor pain. They're still capable of consenting. So I'm always a proponent for having anesthesia come in to do a consult early on if there's like questions or concerns. Is something that they aren't maybe a fan of or not in their plan, but they're open and they want to just know more, like just have them bring anesthesia in. We'll chat.
Yeah, I think that's so important to unpack whatever fears they may have, right? Because there can be fear around epidurals.
Yeah.
And the sooner we unpack that, the better. And I love that having the anesthesiologist come in and not to start the epidural, but just to have the conversation and answer any questions that they might have, because they may not otherwise have that opportunity.
Yeah. Well, and the other thing is too, like we're not always immediately available.
Oh, yes.
So
We know that.
yes. We know it. Oh, I hate when I have to make a woman do an epidural, but sometimes we are just stuck in the operating room with another patient and we're not available for an hour or two, sometimes longer, unfortunately. So if it is something that, you're thinking of, it is kind of good to start that process earlier rather than later. The other thing that is kind of counterintuitive, partially because there was this concern of getting the epidural too early, it can be too late in the sense it can be really challenging to put an epidural in if you are very active and your contractions are less than a minute apart and you really can't sit still. It does make it a little bit more challenging, and maybe your risk of that dural puncture headache goes up a little bit, or the risk of failure, because we have to be quick and you're moving. And so it can be a little bit more, not dangerous, but that risk profile is a little bit elevated, I would say. So yeah, we love putting epidurals in when we have a nice couple minutes between contractions and stay still and communicate still. I feel like sometimes women are so far gone and they cannot cope any longer. And we're just doing everything we can to get them positioned for that epidural. And then they feel so much better after. But yeah.
Mm-hmm. I've had a lot of patients where they have the fear of, I won't be able to sit still. I have to move.
Yeah.
And they're moving in the bed. And then you just ground them and say, okay, this is it. And it's incredible how they can do it just for that, whatever it is, 5 minutes, or they just do. And they're like, oh my gosh, I can't believe I did that. Because before they're like,
I know.
Mm-hmm. And on that note too, I think the team is not just unique at the hospital we work at, but many other places too, is really good at communicating and kind of planning the timing, putting the feelers out. Like if this laboring mom thinks that she would like an epidural, having a beat on where are things at with the book cesarean section slate, and when will the anesthesiologist have the time to come and start it? And do you want to get to that point where you're just like, I can't take it anymore? Or do you want to get it when there's a little window of opportunity? You feel like you can sit still, right?
Yeah.
So just working together and communicating that way. We all really want good outcomes for our moms.
So important. Yeah. And some women really want to experience the intense labor,
the beast of the belly,
yeah. Maybe not for as long as if we're caught up, but, so sometimes that's okay. Like, feel it and then I'll help you feel better. But now you've experienced true labor and now let's have a little rest before you push. Yeah. It's, I'm so used to women contracting though. Like that's the other thing is like, oh, I'm afraid I'm going to move. I promise you, I'm not going to do the part where I need you to stay still, like during an
At the
active
peak of the contraction.
Yeah.
It's really obvious when you have the contractions.
Yeah. And like, I can usually sense when one's coming on. So then I will pause, we'll get through that one, then I'll keep going. Yeah. Even when I'm just putting the numbing freezing in the skin and people jump, like, they're always like, oh my God, am I going to have a nerve injury? No, like it's okay if you jump at that part. It's just the part where we're trying to place that catheter into that really sensitive spot. And we just need you not to move for a sec. The other thing that sometimes people get a bit panicked by is either during the procedure, you get kind of that like electric shock down one leg.
Yeah.
That nerve zing. That's very normal if that happens. What we don't want is for that to persist. So a one-time kind of zing or electric shock is totally fine as long as it goes away. It's usually just from that catheter or that little tube just kind of brushing up against like a nerve root. But if it persists, then that's something that we would probably either move to a different spot and replace the epidural. But yeah, that can be a little bit alarming if you're getting your epidural and you all of a sudden get this shock down your leg and you're like,
it scares the nurses. I had one the other day and they were arm holding and she'd jump.
I know. It scares us too a little bit, but it's usually.
And it's just temporary. It's like a zing and then it's gone.
Mm-hmm. Yeah.
And so we always encourage people to use their words.
Yes.
If they can. Yeah. And just say which side that it was on and it helps you with your job, right?
Exactly. Yeah.
It's interesting. So the three of us have all had C-sections and
yay C-section.
Pro C-section. Yeah, pro. I had the best experience times 2. I don't know. How is
that's so wonderful? Well, with my first, I labored first. So I had the epidural. And then with my second, it was a book C-section. Yeah. But with both of them, of course, you have an epidural and a spinal. You have that freezing that goes in. And I would say that was the most painful part of it. And it wasn't that bad, like compared to contractions, that's temporary stinging. It's like, oh yeah, it's burning a bit, but that was the hard part. Yeah. And then it seriously was just that feeling of pressure, not painful pressure, but like pushing on, similar to if you've had some freezing with dental work.
Absolutely.
And and it did the trick. Like it did its job. Yeah. And made things very pleasant.
I know. It's one of those things that I think it just truly sounds worse than it is, needle in the back, like, but, similar experience, like my IV hurt more than my spinal. I just loved it because I loved experiencing what I was providing to women for many years. I loved experiencing that myself. I felt like I could better relate. And, it was a beautiful spinal. Thank you, Dr. Sundarani. And Dr. COVID Lee was my OB.
Oh my God.
And they're both on the show.
Oh, excellent. So it was great. But there were certain things I was like, oh yeah, I kind of forgot that could happen. Like you kind of feel like you're in a tunnel sometimes. You get that kind of like muffled hearing. That's actually a very normal response to spinal medication.
So did you feel that while you were sitting up or when you lie down?
When I lay down and then, and just the shakes. I guess we didn't talk about that, but
yeah. Oh yeah.
The shakes are so common. Oh my gosh. For me, Demerol did the trick.
Oh, nice.
Yeah. But, we have ways of treating those shakes. Yeah. For the listener, especially if you're laboring and you need a C-section and you're in a cold operating room and then we're topping up your epidural. So the medication in the epidural, the labor itself, the operating room temperature, these can all make you have some shakes. And it's not always because you're cold. It can be just completely involuntary. Very normal.
Anything you can do to get rid of the shakes?
There's 2 medications. The Demerol is very helpful, but it does have some opioid properties, so you can get a little bit sedated with that or feel a bit loopy. And some people get quite nauseous or even vomit with Demerol. More recently, we're using a lot more dexmedetomidine, which acts centrally. It's like an alpha blocker, but it can help reduce the shakes. It's just not as quick or as effective as Demerol, but still, but there are things we can do. Warm blankets.
Yeah.
Always adding
Yeah.
Constantly running out to that blanket warmer.
True that.
A patient told me once on TikTok she learned to stick out her tongue if she had shakes. Is there anything to that?
I've heard that, or like touch the roof of your mouth with your tongue. Kind of distracting things. Yeah. I think it can help temporarily.
Yeah. Oh, interesting. Yeah. TikTok for the win.
Oh, yeah.
Look at
No,
that.
it's true. Yeah, I hear midwives telling patients that too. Back just to the overall C-section experience, because I forgot to mention this. And this is something that I do that I think is pretty unique to me. But you know how we have baby on the warmer and mom and dad, and there's that blue drape. I always try and make like a little window so that mom has eyes on baby. Because I think if mom can see even just like some feet in the air while they're being assessed by the NICU team or the nursing team or midwifery, I think just knowing that they can just look over and see their baby, it just makes them feel so much more calm.
Yeah.
And I've seen that. And it's so easy. You just like add another little clip on the drape. So I try and always have baby visible to mom and to dad. And dad is free to like walk back and forth. But sometimes if they're a little bit lightheaded, we don't let that happen. But
yeah, all those things, they improve the birth experience, right? For the family.
I really try and prioritize skin to skin too, even if it's just for a few minutes. I know it's not ideal because you're still having surgery and you're lying pretty flat, but it can be done. And and sometimes it just makes the rest of that surgery just go by so quickly, right? If you can just look at your baby and
smell them.
I know. Sometimes they're like sucking on the mom's like chin and stuff.
Yeah.
So do try and do skin to skin wherever possible.
Yeah.
The things we see.
I know.
Oh my gosh. So in Vancouver, it's family-centered care. We had big birthing tubs in a lot of the rooms, like up on single room maternity. And the dads, they just jump in with the moms. And so I taught childbirth education. I'm like, okay, so bring your swimsuit, and there's no Speedos allowed at the hospital.
Oh my God.
If mom's in the shower, she wants you to join, you got to keep it covered up.
Yeah.
We're used to naked women, naked guys, not so much. So just, we don't want to see it.
Oh my gosh.
Yeah.
Okay. Another question for you. If you could change one thing about how the system supports women during labor and birth, what would it be?
Oh man, pick one thing. I feel particularly passionate about treating pain during cesarean section lately. So yeah, I'd change that. I think it's hard because if the spinal fails or the epidural fails, sometimes we see that as, talking about failure here. Sometimes we see that as a personal failure, but I think we need to move past that. And really it's the block that has failed. It could have been done extremely by the book. There's things that can happen. And so I think we need to be better at identifying patients who are at risk of experiencing pain during cesarean section. So people who have had prior bad experiences or enhanced sensation during surgery, if this is their second or third C-section, for example, people who are on chronic pain medication or have a history of trauma or anxiety, like these are patients we need to be a little bit more, I think, cognizant that they're at risk for this and that it could be quite detrimental to their mental health and well-being and their postpartum experience. And so I think not brushing off pressure and pulling as just pressure and pulling, like for some women that is painful. And so I think constantly checking in with women during C-sections and really having a low threshold to escalate care, whether that's IV sedation or analgesia, and then or converting to the general. So I think paying more attention to that rather than just, we're almost done, just 10, 15 minutes, just suck it up. Like, it's just pressure. I hate that.
I don't like it.
Yeah.
Do you like it?
Not at all.
Good. We have a consensus here.
Yeah.
Yeah.
I mean, to be truthful, it doesn't happen that often.
No. Well, actually, it's probably about, from the most recent literature, about 8%
Okay,
of women will have pain during cesarean section.
Is there things that you test beforehand?
So I think trying to test from a few different ways. So Ice is one way. Typically, if you have loss of motor strength, like a dense motor block, then you're going to be fine because you know if those are the most resistant nerve fibers, then you've pretty reliably knocked off all the pain, the touch, the pressure before you get to the motor. So that's quite reassuring. So, but then I also am doing like pinprick along where they're going to be making their incision. So do you have any sensation here? Working my way up with the blunt tip needle and then also using cold and temperature. So if you can reassure yourself that they're not feeling the temperature change, they're not feeling the pinprick or the sharp pain, and they're not able to move their legs, those are really good signs that your spinal is going to be just fine for surgery. Does it mean 100% of the time you're not going to feel anything? No. But those are sort of good metrics to go by. And then the kind of the classic blood pressure drop, which it's kind of reassuring for us to see because we're like, oh, okay, that's going to work well.
It's a good block.
Like, yeah, it's gonna be good.
The woman's throwing up because
I know.
blood pressure is dropped, but the anesthesiologist is like, yeah, I nailed it. It's just temporarily feeling like crap.
Yeah, it's usually a temporary thing. And not everyone gets that because we usually will run like the phenylephrine medication because what happens is you get this like profound vasodilation. And so you just get your drop in blood pressure. You don't have enough blood or as much blood returning to the heart. So by giving a medication that just helps to constrict those blood vessels peripherally, which is phenylephrine, then you kind of combat that change that happens physiologically. That's kind of that's a fun part of my job too, is like anticipating what's going to happen and trying to fix it. And yeah, it's fun.
That and seeing all the babies, because I know you love the babies.
Babies, especially I know I'm done with my family. So now I'm like just living vicariously through other patients. And yeah.
We have one more question for you.
Yeah, let's go.
So what do you want every expectant parent to walk away knowing after this conversation?
I think that, we're on your team. We all have the same goals in mind for the most part. Healthy mom, healthy baby. And if you want anesthesia services involved in your labor, we're there. There's no perfect time to get an epidural. It's whenever you feel like you are ready for one. And please just ask us any questions you have. We really do try and do our very best treating your pain and providing a good experience. So let us know how we can best support you, especially in the operating room. That's our home. We're there all the time.
And because it's your home, you help people feel relaxed.
Yeah. Because I get it's so scary walking into an operating room and you've never had surgery before or minimal exposure. And yeah, this it's so comfortable for us. I know where everything is. I know the machines like the back of my hand. I know what I'm doing. So yeah, let us help you through it and we can have a good experience together.
Well, thank you so much for coming and speaking with us today. We really appreciate you spending the time.
Yeah, it's been fun.
As do our listeners, I'm sure.
Mm-hmm.
And if you were happy with what you heard today, please subscribe, follow on all the platforms. We're on Spotify, YouTube, Facebook, Instagram, TikTok, and we're still working on Apple Podcasts. Thanks for joining us.
If you have any questions about what you heard today, please reach out. Sarah and I would love to hear from you. Email us at birthslater@yahoo.com. That's birthslater@yahoo.com. We are here to support you every step of the way. And now for the legal language. This podcast is solely for educational and entertainment purposes. This podcast is not intended as a substitute for professional advice from qualified individuals involved in your prenatal, labor, and postnatal care. Every pregnancy and birth is different, so always talk to your healthcare provider about what's right for you.